All right, good morning, everyone. Please give us a moment. We can go to the slides, please. All right, thank you so much for the kind welcome, Remo. And all right, here we go. All right, so I'm going to be starting off talking about frontline treatments for multiple myeloma. The field is moving at a very rapid pace, and what I'll try to do is to cover most of the studies and try to share with you the framework that we are trying to move towards. These are my disclosures. So the learning objectives, I'll take you through our current frontline approach or thought process or paradigm as we treat newly diagnosed multiple myeloma patients, talk about the initial induction regimens for both transplant eligible as well as ineligible, and how we're thinking about distinguishing treating standard risk versus high-risk patients, and then try to bring it all together for the transplant ineligible patients towards the end of my talk. Now, this is a slide that has been utilized quite a lot over the last 15, 16 years. We start patients on treatment when they're newly diagnosed with induction therapy. It used to be 2 drugs, then became 3 drugs. For transplant-eligible patients, they go on to receive a stem cell transplant. And then we proved in trials that keeping them on a single-agent maintenance with lenalidomide improves their survival outcomes, so that became the standard of care. So we had this continuous therapy model. And of course, you pay attention to infection prevention, bone health, pain management, physical medicine, and rehab. And with that supportive care approach, with 2 or 3 drug induction, with or without transplant, single drug maintenance, if we look at the survival outcomes for standard risk patients, it's about 13 years. For high-risk patients, it's about 7 years. And so that's kind of the benchmark that we are trying to build upon. And when patients have a relapse, you restage them and try to pick the best options at that particular time that gets them into the deepest responses. So I'm going to share some insights with you. I do feel that we are in a very promising era of immunotherapies. We also have the tools necessary to really draw the line where and when we need to treat patients. We are currently defining where in that journey from MGUS to smoldering to active myeloma, we can draw that line and start treating patients. And many of us are trying to combine myeloma genomics, bone marrow microenvironment, as well as immune profiling to determine where that cutoff would be. And you can utilize both predictive and prognostic modeling to see which treatments will work for what subsets of patients. So that work is actually ongoing. Several groups are doing that. Then defining cure, I think the first step to get to curability is to have undetectable myeloma levels, right? So MRD assessments have been incorporated in myeloma clinical trials now for more than 15 years. We had, with an effort with, Dr. Anderson and others led over the years, MRD recognized as a regulatory endpoint for accelerated approval in the relapse setting. But we are taking that to another level. So we feel that achieving sustained MRD negativity will help us get to that, curability or functional curability of myeloma. And so that becomes a very important component of how we're now working on optimizing induction therapy, consolidation and maintenance strategies, and eventually define the duration of treatment. So when I say consolidation, I consider high-dose melphalan with stem cell rescue in that category. Our future quote-unquote consolidation strategies may employ immunotherapy combinations. How long do we need to treat? And this is just my view. For standard risk patients, I do feel that 2 years of sustained MRD negativity at 10 to the minus 6 may be sufficient, and several groups are testing that hypothesis right now. For high risk, we're kind of undivided, but agree that it could be at least 3 years. And then, of course, we want to focus on improving that cure fraction without compromising on safety and quality of life. So that also starts becoming a very important piece of the whole conversation. So with that being said, I'm going to bombard you guys with a lot of clinical trial data and see where we're going with this. So the first thing is that I want to share is our definition of high risk. The definition of high risk is changing. This new consensus international myeloma work. I'm actually want to make sure. So these slides are not mirroring correctly, but it's okay. So the International Myeloma Society and the International Myeloma Working Group came out with a consensus definition, which is mostly genomically based. The only feature that you see here, which is not genomically based, is a high beta-2 microglobulin levels. And that remains as function of proliferative disease as well as a function of burden of disease for now. But at some point in the future, with the current treatments we have, that too might go away. So the trials I'm going to be sharing with you, I can actually end my presentation on this particular slide because this shares with you what MRD negativity levels different strategies get us. So on that right side, you see the box with 8 different randomized studies, both in the transplant eligible as well as ineligible setting. In the top part of this slide, you see the summary of what MRD negativity 10 to the minus 6 levels one gets after a quadruplet induction therapy. It's about 20 to 27%. Then if patients get a transplant, you can increase that MRD negativity rate to up to 45%, depending on which clinical trial you look at. But with a 2-drug maintenance, continuous maintenance model, you can get about 2/3 of myeloma patients to MRD negativity at 10 to the minus 6. What about sustaining that MRD negativity? About 47% of patients sustain it beyond 12 months. So while we've come far, and the survival outcomes speak to that, in terms of getting majority of our patients to MRD negativity and keeping them there, we still have our work cut out for that younger transplant-eligible patient population. For the older population that are transplant ineligible or deferred, the MRD negativity at 10 to the minus 6 that you get with a quadruplet induction followed by 2-drug maintenance is about 46%. And what about sustained MRD negativity at 10 to the minus 6 beyond 12 months? It's in about 1/3 of the patients. So while we've come far, we still have work to do. So if there are young people sitting here who are thinking about whether to choose myeloma as a field, this is the right time to get in. You are going to have a lot of work ahead of you. This is supposed to be an inspirational slide. I did not have this when I was starting in the field. And certainly, my senior colleagues, who have been part of that journey of success can attest to that, even more than I can. So let me start by sharing the transplant eligible data from the 3 to 4 drug story, or the 3 to 4 drug induction story. So that story started with a proof of concept trial called the Griffin study, which added daratumumab to VRD in the induction, post-transplant consolidation, and then dara-len as maintenance. And what that trial showed is that you can improve MRD negativity by adding the anti-CD38 monoclonal antibody compared to the RVD regimen alone. And it starts translating into progression-free survival benefit as early as the 2-year mark. And that distinction continues to emerge with the passage of time. Now, the primary endpoint for Griffin, which was a randomized phase 2 study, was just response-based. But you start seeing this PFS signal. What was also very remarkable about this study is at the 4-year mark, the overall survival rate at 4 years was around 92 to 93% for both arms. So that speaks to the same message I was giving on my initial slide of how far we've come in improving survival outcomes for myeloma. And we have to make sure we maintain that benchmark and not compromise the quality of life and safety for patients. Now, the same signal was seen in the Perseus study. The Perseus trial was a very similar design to the Griffin study, but powered for progression-free survival. It was a phase 3 study. So you can see the design is the same. I want you guys to also pay attention to the median age of this patient population. So patients who were treated on Perseus and Griffin, the upper age limit of enrollment was around 70 years. So when we start talking about approaches for myeloma patients, we have to start keeping in mind the patient population. So the median age of this population was around 60 years. And we saw the same picture. I mean, essentially, the Griffin curves were, and the Perseus curves are superimposable. The 4-year PFS rate was 84. The slides are moving on their own, and I'm not doing this. 84.3% versus around 68%. Very similar curve to what you saw with the Griffin. And the same OS rates around 91, 92% at 4 years. So the Griffin proof of concept was actually proven for PFS benefit in the Perseus trial. Now, we've recently also had an analysis done to look at high-risk patients on the Perseus study and see if they got the same kind of benefit as standard risk patients and whether they did better or worse or about the same than the RVD arm. And what we see is, yes, the depth of response is better than RVD. You have better MRD negativity rates, both at 10 to the minus 5 and 10 to the minus 6, but they are not at the same level as that for standard risk patients. So our group went back, looked at the Griffin data, and another trial called the Master study that was looking at another quadruplet, DARA with carfilzomib Lendex or DARA KRD, and said, let's take a look if there are any differences between the standard and high-risk patients. There were already some single-arm studies that were reporting that there might be a greater depth of response for high-risk patients if you use carfilzomib as the proteasome inhibitor of choice. So when we look at the CR or better rates, they kind of look about the same. But then when we start looking at MRD negativity, that's where it gets interesting. So MRD negativity for high-risk patients is actually better. You get deeper MRD negativity when you use carfilzomib as part of that 4-drug induction approach for high-risk patients. And so this was an exploratory study. We were comparing 2 different studies. These were 2 separate populations. But then came the ISKIA trial. This was presented as a plenary abstract at ASH in 2023. And they only reported on MRD negativity. And this trial asked the question, okay, you have the standard of care arm as KRD, or as adding isatuximab, which is another anti-CD38 monoclonal antibody that's currently approved in the relapsed myeloma setting, and said, let's take a look at the MRD negativity rates with this approach. So randomized phase 3 study looking at MRD negativity endpoints. And guess what? It did show better MRD negativity, the same kind of message that we were seeing with the Griffin and the Perseus and other trials. But more importantly, looking at the high-risk karyotypic abnormality patients, either with 1 or 2 or more, the MRD negativity rates you're getting is quite remarkable. In about 2/3 of the patients, you are able to get to 10 to the minus 5 or 10 to the minus 6 MRD negativity, and you're not getting that with the triplet combination. So one of the things that we do in our practice, and I'll show this in a slide a little later, is pick carfilzomib as the proteasome inhibitor of choice for our high-risk patients. Now, the next question is, what does daratumumab add in terms of maintenance for patients? Cassiopeia was the first clinical trial that actually looked at using daratumumab every 8 weeks versus observation in patients who have received either VTD as induction or dara VTD as induction. So essentially, there were 4 arms of the study. The first randomization was VTD versus dara VTD as induction. And this trial read out positively that 4-drug induction is better for depth of response and PFS. But the second randomization was that of maintenance with data every 8 weeks versus no maintenance. So this clinical trial also had MRD negativity kind of built in at specific time points at 6 months, 12 months, and 24 months, and looked at those 4 different arms based on landmark analysis at 10 to the minus 5 and 10 to the minus 6. So what this slide shows you is that if you continue data throughout the treatment phase for patients, you get a higher MRD negativity rate. But the group that benefits the most, that gets the most bang for the buck from data as maintenance was the VTD, the triplet arm. So you get some benefit, but the most stark benefit you get. So does this convince me to use data on its own as maintenance treatment in lieu of lenalidomide? No, it does not. But can I use data in someone who cannot tolerate lenalidomide maintenance? Sure, I think it might make sense. And that question also got answered more recently in the ORIGA trial, where patients who got a triplet induction therapy were randomized to getting dara-len or len as maintenance. And the primary endpoint for this study was, can you convert more patients from MRD positive to MRD negative at 10 to the minus 5? And so this study actually demonstrated that you can do that more effectively with dara-len compared to len. Now, when patients get to MRD negativity, they have wonderful PFS curves, but significantly higher proportion of patients actually get to MRD negativity if you use dara and len together for those MRD positive patients. So this is the current approach that our group has for the transplant eligible patients. For standard risk patients, we're kind of following the Perseus clinical trial. But as standard risk patients get to the maintenance phase, we are still comfortable using lenalidomide as part of maintenance strategy. And then if someone cannot tolerate len, we use dara. There are situations, however, if now we are having this discussion within our group, if patients in the post-transplant setting are still MRD positive, we are comfortable using dara-len for that particular situation. So we'll end up probably updating our approach later this year as we get more of the ORIGA data available to us. For high-risk patients, it's dara-KRD as induction. We prefer doing a PI IMiD maintenance, a la Forte trial, a la Ischia trial. And then if for any reason patients cannot utilize a proteasome inhibitor, dara-len is a reasonable second choice for those patients. For older patients, we've started to think in a different fashion. The goals of care are a little different. You want to make sure that the patients respond and continue to respond, but you also have to pay a lot more attention to quality of life. And this is where frailty assessment becomes important. So for our frail elderly patients, we follow the MAIA clinical trial, the dara-lendex combination. And we typically use the dara-lendex for at least 12 months. We try to use the regimen as such. If patients have had their plateau of response, we're comfortable dialing therapy down to just len maintenance alone for standard risk patients. For high-risk patients, they need more than one drug. Len alone is not enough, so we continue them on the MAIA trial as such. For fit and intermediate fit, we actually have more data now. So we have 2 clinical trials that have shown that 4-drug quadruplet induction is better than 3-drug, and I'm going to talk a little bit more about that. So our group utilizes the anti-CD38 RVD induction for fit and intermediate fit patients. And then for standard risk patients, we are comfortable again using a single agent, maintenance strategy for those patients. But for high risk, it's a 2-drug maintenance strategy. So those 2 trials are the IMBROS study. The IMBROS trial was done in transplant ineligible patients, RVD followed by RD as maintenance, RVD induction followed by RD. So essentially the SWOG 777 trial kind of design was used as the standard of care arm. And isatuximab was added in the induction and maintenance phases of treatment. And the primary endpoint for this trial was progression-free survival, which was met at the 60-month mark, 63.2% PFS rate compared to 45.2%. And the median PFS was already reached in the RVD arm at around 54 months and has not been reached for the ESA RVD arm. The MRD was an important secondary endpoint, and that too was better in the 4 drugs versus the 3 drug combination. And the OS data is immature because the follow-up is only around 5 years, but we'll see how these data emerge over time. The second trial was the Cepheus study, very similar kind of a design, but the differences were in the primary endpoint. The primary endpoint for the Cepheus study was MRD negative CR rates. Secondary endpoints included PFS, overall response rates, sustained MRD negativity. And here, the SWOG 777, VRD induction followed by RD as maintenance was, again, standard of care treatment, and subcutaneous daratumumab was added as part of induction and subsequent maintenance in the experimental arm of the study. So with the primary endpoint of MRD negativity at 10 to the minus 5, it was met in favor of the DARA arm of the study, even in this older patient population. It was positive for 10 to the minus 6 MRD negativity threshold, as well as for sustained MRD negativity beyond 12 months. And they did translate into PFS benefit. So very similar curves, again, to what you saw with the MROS study. Median PFS not reached at the 54-month mark, 68.1 versus 49.5. I am coming to my conclusion slide, so bear with me. So bottom line, we have to pick the right strategy for our patients that get them to the best depth of response in that first year of diagnosis. We can do this effectively with anti-CD38-based therapies in the frontline setting during that first year for both transplant eligible as well as ineligible patients. There is emerging data with dara-len as maintenance. And then future strategies, we are going to have bispecifics, some biomarker-driven therapies being incorporated, and never put your foot, always put your best foot forward for the high-risk patients. Thank you so much.